This is MAX, a highly mobile, self-contained emergency life support and resuscitation system, which uses a small team to perform clinical procedures rapidly. The patient is transferred to MAX, supported with an open airway, oxygen-enriched ventilation, and efficient cardiac compression. An electrocardiographic trace is visible, and a venous cut-down is underway. At its base station, usually the intensive care unit or the emergency room, MAX is ready for immediate use. An illustrated checklist describes in detail its contents and the specific functions of each resuscitation team member. Review of this chart by those responsible for maintaining and restocking MAX following its use will assure that all medications, supplies, and equipment are available quickly. All controls are preset to save time and avoid errors under emergency conditions. The folding footboard retains the storage drawers in transit. The drawers are unlocked and can be readily opened and removed without a key. Logical and compartmentalized storage aids inventory control. Medications are stored alphabetically in foam modules. This permits rapid identification of missing items, which should then be replaced. Once opened, a special lock prevents drawer closure. An open drawer indicates either use or unauthorized entry. After inspection, the maintenance key is used to completely close each drawer. The footboard is latched securely and the compressor arm is locked at the top of the column, aligned with the long axis of the cart. The work lamp is secured to the compressor column with an elastic band. MAX's battery is charged through a drop-off umbilical attached to the wall. In cardiopulmonary arrest, immediate oxygenation of vital organs is mandatory. Mouth-to-mouth breathing, or respirator, and external cardiac compression should be used immediately. Never delay support of a patient by awaiting either a formal resuscitation team or special equipment. When MAX is moved, umbilical separation automatically energizes MAX's power supply and electronic equipment. There is no off-on switch. MAX is highly maneuverable, moves quickly, will not overturn, is controlled with a brake, and turns in its own length. Transferring the patient to MAX places him in a mobile intensive care unit. All equipment is applied by team members acting swiftly, simultaneously, and without delay or mutual interference. The patient, MAX, and the resuscitation team interact in a logical system quickly and effectively, integrating the clinical skills of the team, supporting equipment, and the needs of the patient. All airway-related equipment is at the head, where the anesthesiologist is stationed. The wall oxygen hose is plugged in, and preliminary hyperventilation begun. The oxygen power external cardiac compressor is applied. Confirm that the master valve is on and that the compressor force control knob is turned completely off to the full counterclockwise position. Turn on the compressor switch. Turn the force control knob clockwise to provide approximately 1 1/2 to 2 inches of chest depression for the typical adult. This requires 60 to 90 pounds of pressure. The piston cycles 60 strokes per minute. The piston, which is placed on the lower half of the sternum directly in the midline, is returned by natural chest elasticity. A first check of compression effectiveness is made by palpating the carotid and femoral pulse. Turn the ventilator switch on. The pressure-limited synchronized ventilator automatically ventilates the patient during a brief diastolic delay after every 5 cardiac compressions. The ventilator will also function without cardiac compression as long as the compressor force gauge indicates at least 25 pounds of pressure. Confirm adequate air exchange by watching the rise and fall of the chest and with the stethoscope. ECG leads have pre-attached sterile needle electrodes and are placed subcutaneously in the extremity nearest the lead pocket. As soon as compression and ventilation are established, attach the third lead. The scope produces an ECG trace immediately. Establish a venous group by cut-down, percutaneous catheter, or other appropriate technique. After preliminary ventilation, refine the airway by endotracheal tube and aspiration as necessary. Squeeze the trigger on the aspirator pistol grip to control timing and degree of suction. After establishing basic support of the patient, plug in the AC power cable to conserve batteries for independent operation. If hospital electrical service fails, MAX automatically switches to its own power. When service is restored, all circuits automatically revert to hospital power. If defibrillation is required, confirm the diagnosis and turn on the defibrillator. The maximum 400-watt second power setting is usually employed for ventricular fibrillation. Apply electrode paste or saline pads, and with at least 20 pounds of pressure, place the electrodes to the right of the sternal notch and at the cardiac apex. Both compression and ventilation are continuous as the defibrillator is charged. Stop the compressor, but retain piston position and force control setting while determining if defibrillation has succeeded and a cardiac output is adequate. Minimum preparation permits transportation of the patient. Check ventilator and intravenous connections for security. Unplug the line cord. Store the wall oxygen hose after turning on one oxygen tank. MAX will now function independently. A distinct change in cardiac compressor sound warns that oxygen pressure will fail in 10 seconds. Turn on the second E-tank immediately to maintain oxygen pressure while replacing the first tank. Never operate from both E-tanks simultaneously. And move the patient only while operating from one tank with the second unopened tank in reserve. If wall oxygen had not originally been available, one E-tank would have been used while awaiting a large external tank to receive the wall oxygen hose. Each of the two E-tanks will provide oxygen for approximately 15 minutes, or a total of 30 minutes. If no external oxygen source were available, alternating between and replacing E-tanks would provide adequate oxygen. The team leader confirms the condition of the patient, and with assisted oxygen supplemented ventilation, intravenous fluids running, and ECG trace visible, MAX can provide all supporting modalities, including cardiac compression in transit. Even in an elevator, for example, one can cope with ventricular fibrillation. If emergency surgery is required, MAX saves critical time and continues to support the patient while functioning as an operating table. use conventional draping for peniotomies. The compressor arm and lamp can be quickly removed to avoid interference with thoracotomies or laparotomies. You've seen Max used for resuscitation and emergency surgery. As a general-purpose emergency life support system, Max may transport critically ill post-operative patients, support patients between emergency room and operating suite, or sustain a pulseless patient while moving him to fluoroscopy or cardiac catheterization laboratory for transvenous pacemaker catheter. Max is self-contained and may be used outside the hospital. For example, in a factory or stadium, wherever masses of people are found and the need for emergency care can be anticipated. This film is only an orientation to the Max system. Acquire the necessary practical skills by repeated drills and practice in basic resuscitation and physical handling of the controls and equipment. Remember, Max's effectiveness and your patient's survival depend on you.